This is the Pediatric Podcast from Health Ed, where we interview leading experts on important topics that can positively help your practice.
Hello, my name is Rebecca Overton. I'm a practicing GP. Today I'll be speaking to physiotherapist Alison Slater and psychotherapist Dr. Jade Barclay about fascia and hypermobility, when to suspect hypermobility, how do you assess it clinically to get an accurate diagnosis, and whether imaging is of use. Alison Slater is a physiotherapist working in Sydney. She has a wealth of clinical experience as well as postgraduate study, including a Masters of Manual Therapy and a Masters of Public Health. She's taught and worked extensively throughout Australia and the United Kingdom and has been in solo private practice in Sydney since returning from the UK in 2003. Her passion for all things fascia was ignited in 2007, and since that time she's travelled worldwide to attend numerous fascia summer and winter schools, dissection workshops and fascia research congresses. She's privileged to have presented on the anatomy and physiology of fascia and application to manual therapy at this year's Australian Physiotherapy Association's Scientific Conference in Adelaide. Alison has published in peer-reviewed journals as well as contributed to book chapters. Alison, welcome, and thank you for joining me for today's Health Ed podcast. Would you like to tell me a little more about yourself?
Thank you, Rebecca, and it's an absolute privilege to be here. I think the sort of bio said it all. I've been a physiotherapist coming up to 40 years as of February, and I've seen a lot of changes over that time. In 2007, I had the privilege of being at the World Congress of Low Back and Pelvic Pain over in Barcelona, and I met a gentleman by the name of now Professor Robert Schleip, and he started talking about fascia, and I was absolutely enthralled because obviously, you know, I'd covered the joints and the muscles and the nerves and the blood vessels and all of that sort of stuff. Fascia just seemed to bring it all together. That's what really ignited my passion.
Fantastic. And Dr. Jade Barclay, you're a Maori Australian researcher, therapist and science educator focused on health equity, and your PhD investigated diagnostic delay and prevention for pain management with hypermobility, neurodiversity and multimorbidity. And you've got an MBA, Masters of Public Health from New South Uni and a PhD in medicine from the University of Sydney, where you're also a research fellow in digital public health. Jade, can you tell me a little more about yourself?
Thank you for having me. This is wonderful that you're covering the topic. So I was originally a data analyst for years, and then for reasons that nobody could explain, I got too sick to work before the world had invented Zoom. So I couldn't work in a building. I could do the work, my brain was fine, but I couldn't commute without injury or fatigue, and nobody made any sense of that. So I was too sick to work and too bored not to, so I studied as much as I can, because in this country you can do that, right? And I got more and more interested in health and more interested in research. And that kind of culminated with the hypermobility thing didn't even come onto my radar until probably about 24 years after all of the mystery illness stuff began. And that seemed to be the clue that tied everything else together. And the more that we looked into hypermobility and connective tissue, the more that it seemed that fascia and dysregulation overall were at the core of all of this. And if we could understand more about those things, we could actually start to manage all of the other ones. So that's my short background.
Well, I'll look forward to hearing about your lived experience of hypermobility and other difficulties that may have presented. But what I might ask, Alison, is can you start with telling us what is fascia?
Wonderful question, and such a good place to start. So, Rebecca, fascia basically touches every other system in the body: bones, muscles, organs, nerves, and vessels. It's made up of collagen, primarily type 1 and type 3 collagen. Type 1 collagen having more tensile strength, so it's a very effective force transmitter. We think about tendon, for example. Cells, we've got fibroblasts, fasciocytes, mast cells, adipocytes, macrophages, chondroblasts, chondrocytes, osteoblasts, osteocytes. So it starts to give us a little bit of an idea of the diversity of tissue that fascia has a very real connection with. And of course, we've got the extracellular matrix. That's the background that all of these tissues sit in. And basically, the condition of the extracellular matrix, or the ECM as we might do to make it a little bit quicker is basically the litmus paper that dictates how well we move and basically our overall well-being. So the interesting thing is that fascia appears in different forms, in different places, depending on what the demand in that area is. So I mentioned tendon. It's a big force transmitter. But around muscle, I want you to think of it a little bit, and I use this analogy all the time, like cling film sitting around a chicken breast. We all can see the cling film. That's what we call the epimysium of the muscle. We also know, given our background, that muscle is divided up into fascicles, bundles of muscle fibers. Each of those fascicles is surrounded by a separate but connected fascial sleeve, as is every single muscle fiber. So given the amount of fascia in that system, it makes perfect sense that this is where virtually all of our mechanoreceptors are. Believe it or not, we get 10 times more information coming from the fascia than we do from muscle itself. I have a little saying that fascia is the brains and muscle is the brawn, because fascia organizes a lot of our movement. It's also our richest sensory organ. So it houses both peripheral and autonomic nervous system components. So there's 250 million nerve endings in fascia. And with the sensory neurons, they outnumber the motor neurons by 9-1 in some regions. So it's got 25% more nerve endings than skin. And we've always thought skin was our most sensorily, adapted tissue. And that's not the case. We've also got a rich supply of blood vessels in lymphatics, and considering where those vessels lie between the muscle bellies, for example, it doesn't take terribly much imagination to think that if there is dysregulation in the tissue, even if it's not hypermobility, but simply an area where it's sticking due to overactivity or underactivity, then of course we're going to get impingement on some of those tissues. And this has all sorts of implications for fluid exchange in our periphery. And so, of course, it can be one of those things that if we overlook that, then it's going to be a really big problem to try and get people, better. So it also crucially accommodates hormonal and neurotransmitter receptors. And that has a massive application to particularly our female clients. So its integrity is paramount to how we move, how we interact with both our internal and external environments. It also controls thermoregulation and, as I said, our general physical and emotional well-being. Considering that there is not a graduate teaching program on the planet that involves an understanding or a teaching of fascia, I think we're overlooking a really, really big component of human health. So obviously it has a huge part to play in inflammation. We talked about lymphatic drainage before. It has a role in immune function. And in understanding that, so in other words, looking at the body through a fascial lens just gives us so much more information about what could be the primary cause of an issue. So obviously with hypermobility, it's a dysregulation of our collagen. So that's a really big problem on a number of different levels.
So it sounds like our fascia is our connective tissue, and it's sort of an endless web of tissue that continues throughout our body. Can we discuss a bit more what is its role in hypermobility?
Great. So fascia is essentially the body's tensioning system. When it's dysregulated, everything from movement to organ function to pain perception goes haywire. So fascia plays a central role, but also a paradoxical role in hypermobility, in that there's too little collagen. So if there's a laxity in the tissue, in terms of that paradox, in some areas of the tissue, it has been proven with research using ultrasound that at that level of the epimysium that we talked about around that, the muscle tissue, we get a thickening of fascial tissue. So given that fascia is all about how we move, that ease of movement, that glide between the tissues, then of course that's going to be a really big problem for how hypermobile people move. And of course that's going to have implications for pain. So we get it, as I said, a disorganization in those collagen fibers. We get weaker cross-linking. we get reduced tensile strength, so that creates loose structure that weakens the body, since fascia is what is holding everything together and stabilizing it. So the matrix that the fibroblasts deposit during the healing, when people injure themselves, is less robust for these individuals. Wounds close more slowly. They're more prone to stretching and gapping. So that thickening, as we talked about before, is a maladaptive compensation. So in hypermobile EDS and in hypermobility spectrum disorder, the deep fascia becomes thicker and less elastic. And of course, that tissue under normal circumstances is how we generate strength in the muscle and how we transmit that to tissue around it. Remember, we learned about origin and insertions. When we look through a fascial lens, that becomes less and less appropriate, because we're getting involvement of synergists, antagonists, to create better force transmission, but also to protect joints. And we can go, we could have another whole conversation about that. Fibroblasts can also morph into myofibroblasts, and that under normal circumstances is how we heal wounds. For somebody who is hypermobile, those myofibroblasts are chronically activated, so they restrict. It's almost like a scar tissue factory that never turns off. So it produces excess collagen, and of course that's going to restrict the capacity for muscle to glide relative to the other tissue around it. So that's really important for us to take into account. So in the case of hypermobility, we get that inflammatory cascade, and that is added to by emotional stress, believe it or not, because of the autonomic nervous system involvement in fascial tissue. So it can trigger low-grade inflammation, which of course is going to reshape the extracellular matrix, and that densifies that tissue. So again, we lose that gliding. This creates inflammation, and of course, it just keeps feeding that cycle. We also get blunted mechanotransduction. So all of those little nerve endings that we spoke about, those little receptors in the tissue, they aren't nearly as effective when the fascia isn't moving particularly well. And this, of course, puts people at huge risk. These are your clumsy people. These are your people that don't have terrific sort of spatial awareness, and they get themselves into all sorts of problems because they just can't sense where they are in space. And of course, we all know that as proprioception. They produce abnormal extracellular matrix, and of course, as we said, poor wound healing. So despite the fact that the myofibroblasts are overactive at a deeper level, these people can have terrible problems. Sorry, Jade, I keep referring to you as these people, but hypermobile individuals can have enormous problems trying to heal because the skin is also affected, in that it becomes very sort of stretchy. And it's really hard for the myofibroblasts to pull a wound together if it's not getting the cooperation of tissue that is better adapted to that capacity. So there are a few of the things that we can talk about. The autonomic dysfunction, very common in hypermobility. One of the things that people are shocked about is that we can get POTS symptoms. So, these particularly kids, I've come across a lot of kids that as soon as they participate in sport, they faint. And that can get more or less of a problem as they get older. So the other thing about that is that they get reduced peripheral perfusion, and they've got very poor temperature regulation because there's a slower delivery of oxygen and nutrients to wounds. The other thing, and this is definitely going to be Jade's area a little bit later on as we go through, is mast cell activation tendencies. So that increases local inflammation. The pruritus or itching and swelling become a really big problem. There's a delayed transition from inflammatory to the proliferative phase. So again, this just prolongs that inflammation cycle. And of course, as we mentioned before, fragile and easily bruised skin because the dermis is thinner and we get reduced structural support. So that just gives you a little bit of a heads up of what's going on. Jade, I'd like to bring you in here because you wrote a wonderful paper about the comorbidities. So, we can talk about joint subluxation. We can talk about chronic pain, abnormal healing. We've mentioned stretchy skin, poor wound healing. Joints can dislocate. We can get mitral valve prolapse and other heart conditions. Abdominal hernias are quite common, but also pelvic organ prolapse. But there are a number of other comorbidities. Would you like to go into that a little bit?
Absolutely. And when you list them off like that, it can be overwhelming. And it's the thing that helps to hold it all together in your mind is not what is the long, long, long list of things that can happen, but it's more how are these things related. So with all of the mast cells, the autonomic, all of the dislocations, hypermobility in particular is usually categorized as loose subluxing dislocating joints, but it's not just the joints that can be stretchy and loose. Because it is a connective tissue condition, not only can joints dislocate and slip out of place, but nerves can, tendons can. I've got a recurring bicep tendon thing, which is so fun. And it's not that the joint's out of place, the tendon is. And we often get told that hypermobile folks are less strong. Oftentimes we have incredible strength, we just don't have activation, or we will have a SI joint that won't stay in place that prevents us from actually activating or stabilizing. So usually when there's no strength, first we look for activation and stabilization to activate whatever strength is available there. Like I was told for probably 30 years to strengthen, 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 and then had a session in my 40s where you actually handled the dislocation of my SI joint so that my incredibly strong legs could get access to the strong muscles that weren't activating or stabilizing before. So if we focus on activation and stabilization, we can usually access the strength. The other aspect of it is with all of this going on all the time in the body, our bodies can fatigue very quickly. And that can show up as brain fog, but it can also be neural fatigue and less neural activation, which contributes to that activation stabilization issue. So we can fatigue very early. And the same thing with the strength is also with the proprioception. We often have very good proprioceptive systems that are just not getting very clear messages, right? Because the receptor sites in the fascia are getting overwhelmed by all of the inflammation. So again, this is why things like tape and physical therapy and compression can be so effective so quickly, is because we're getting more messages into a proprioceptive system that's usually not, we just need to turn the volume up on the messages so that they can get in. I kind of think that if every specialization in medicine learned their specialization and fascia, we could probably connect the gaps between the silos. It's not just the connective tissue in the body, it seems to be the connective tissue between the different areas of knowledge as well.
And so, Jade, who might have greater susceptibility to hypermobility?
So that varies throughout life, right? So the studies that they've done through childhood and adolescence have shown that both male and female children, about 30% of the population is hypermobile, and that before the ages of 10, and then after, during and after puberty and into adolescence, that reduces down to about 10% of males and about 20 to 30% of females continue to have that. The difference is it's not as symptom producing. So the ones that we hear about, the very, very low prevalence rates, is actually due to a lack of diagnosis, not a lack of actually having the conditions. So the points in life that shows up is it can be in childhood, and that will be when there are multiple conditions. If there are multiples of anything, if you're doing multiple referrals, if you've got multiple body systems affected, if someone's got gastrointestinal issues, 15% of people who will have gastrointestinal issues in one area of the system. If there are two or more areas affected that are just gastrointestinal, about 89% of those people are hypermobile. So when that's the case, you've got multiple things within one system, or you have multiple systems and multiple referrals and multiple diagnoses, that's a warning sign to suspect hypermobility and to start to screen, not only for hypermobility, but also for dysautonomia and mast cell conditions, because those go together. And one of the saddest things that we found is that the mast cell conditions, which really helps with the dysregulation once that's under control, they're usually the last thing to be diagnosed. But if they are the first thing to be managed, they can have a very preventative effect, right? Because it's like the whole window of tolerance for inflammation is a problem. If the body triggers inflammation too soon and turns it off too late, then everything sets that off and nothing fixes it. If we can just address the mast cell activation earlier and not after people have seen, it was an average of between 12 and 21 specialists before anybody mentioned looking at the mast cell side of things. And that helped across the board. The other big group is neurodiversity. So folks with autism, ADHD, dyslexia, dyscalculia, all of various different neurodiversity groups are more likely to have hypermobility and connective tissue issues as well. So those are areas where we do need to be cross-screening. And this is something we've been calling for in the research for about 6-7 years now, is cross-screening between the psychiatric and neurodivergent conditions and the physiological conditions. And because it's been pigeonholed as a musculoskeletal thing for so long, but the autonomic and neurodivergent and sleep issues are all very big clues for looking at this first through a dysregulation lens and then through a fascial and a hypermobility lens.
And Alison, I might ask, what are some of the hallmarks that might cause a GP to suspect hypermobility, and when would we normally see these signs manifest?
Jade has covered a lot of that just then. That was brilliant. Thank you, Jade. But, one of the things, that GPs tend to look at, as Jade said, for so often this has been seen as a musculoskeletal thing. To a kid that can literally turn themselves inside out, it's kind of cute. But the problem is that if it isn't picked up early, that creates massive problems, because we're consistently getting micro injuries that will manifest as people go through different stages in their life. Given that, fascia has a massive amount of estrogen receptors, you can begin to imagine that as a woman goes through puberty and then, perimenopause, menopause itself and beyond, that, it's going to manifest in very different ways. But the sort of things you're looking at, to put it in a nutshell, is, joint hypermobility, joint pain and instability, because these are the sorts of things that kids are going to come in with, or parents are going to bring their children in. So if they've got a history of frequent injuries or slow healing, or they've got that really soft, stretchy skin, they talk about having been in pain for a long time, digestive issues, and there is that sort of autonomic nervous system involvement as well. They're the sorts of things that GPs need to be sort of picking up on. Also in later life, if you're hearing that, I've been told I have fibromyalgia or chronic fatigue syndrome, that symptoms that are medically unexplained, diffuse pain that isn't necessarily just on the joint. There are so many misdiagnoses. And as Jade mentioned, one of the issues is that we're quick to jump in and silo people under various sort of banners, if you like. The problem for hypermobile people is they might have completely different symptoms on different days. And unfortunately, what can happen is that GPs, physiotherapists like myself, unless you're aware of what's going on, you think, oh no, she's coming in again. I never know what to do with this female. And so, of course, they get labelled problem patients, and they get frustrated. They go unheard. They get very disillusioned because no one's listening to them. And then we get frustrated because everyone likes a positive result and everyone likes a quick result. And that's not necessarily what you're going to see with these these individuals, they need to be managed over a period of time. But getting that really thorough history as well as what's going on right now, it may even be worth asking, was this a problem last week? What did you experience last week? Those sorts of questions, just to give you a little bit of an overview of what's going on. So, as Jade said, patients can present with a bewildering array of what are seemingly unrelated symptoms, but putting that all together can be very satisfying in terms of creating a management plan that both you and, more importantly, the patient are satisfied with. The other thing to mention is there a history, a family history of hypermobility? You know, and as we know, a child with ADHD has probably got a parent with ADHD. Are they also hypermobile? So they're the sorts of things that create diagnostic challenges. But once you are pretty convinced that you're on the right track, you can help tremendously.
One of the big clues that's rarely mentioned is having a paradoxical or atypical response to what would be the usual treatment, whether that treatment is pharmaceutical or exercise. If there's an intolerance of exercise, if there's an intolerance of NSAIDs, if there's an atypical response to anti-inflammatories and anesthesia, that's often a very big clue as well. And this contributes to why it's so frustrating. Is we went into depth into the paper of the genes and the various things that are behind these atypical responses. But if somebody says antibiotics have never worked for me, or NSAIDs, they always make me feel bad, or I've never been asleep at the dentist, right? I've never been fully numb at the dentist. I didn't know that anyone ever was, right? Those are also very, very strong indicators to suspect this kind of thing. And the beautiful thing is, I was one of those people who'd never been numb at the dentist. I had entire surgeries and had no idea that you weren't supposed to feel it, right? And it wasn't until interviewing hundreds of other people that I found out that this is actually a common thing. And it's actually in the research literature now, wonderfully. But once you're aware of that, my dentist now does a combination of multiple different things, and I do get numb, which is wonderful. So it's not the end of the road, it's the first clue.
So if we do then suspect hypermobility, what is the best course of action? Is there some sort of clinical management roadmap to help us navigate all the different possible presenting symptoms and signs?
The biggest one is the UK GP EDS toolkit. Where that is hosted now, you'll have to look it up because it was hosted on a different site before and it's been moved from one charity organisation to another, but it is the UK GP EDS toolkit. It is incredibly thorough and it is kept up to date with the latest research, and it's in GP speak. So all of the things of what to see, what to suspect, what to refer, what to do your investigations for. So that is very, very thorough. The second thing is a lot of people will defer to the hypermobile EDS diagnostic criteria, and that criteria is to be taken with a grain of salt. For one thing, it is being reviewed and updated next year. For a second thing, it is known to include a lot of it doesn't include all of the comorbidities that are actually most prevalent in this population. And in the Petrucci paper that we wrote, that Alison's been referring to on the multimorbidity phenotypes, actually looking at the overall multimorbidity picture and seeing what are the conditions not only that they have, also including things that they have at a subclinical level. They may have symptoms of this that don't quite cross the diagnostic threshold, but these are part of the clinical picture, and keeping all of that together. Then the management becomes not looking at symptom severity, but looking at what symptoms are most frequent and how well managed are they. And if each appointment that you work with, you go, what's most frequent? What is daily? What is weekly? What is only occasional? And of your top two symptoms right now, because it does change, which ones are most poorly managed. And if you can always be addressing the most poorly managed symptom, you'll actually get through the whole list one day. If you don't do it that way, it can be overwhelming for everybody and for the patients and the clinicians. And the list can feel bottomless, but it actually isn't.
And so, Jade, you mentioned that UK GP EDS toolkit.
Yes.
Alison, are there any other resources that you might suggest that GPs might use if someone, one of our patients is presenting with all the sorts of symptoms and signs that you mentioned, such as joint hypermobility and pain and instability and injury and slow healing? Is there a resource that you could recommend that GPs might refer to help us find sort of a roadmap in terms of the right diagnosis and how we can best optimize that?
So I actually found the UK toolkit yesterday. I will happily put that up. I have a website called fasciaaustralia.com.au. I'm more than happy to put that on there. I will also put a reading list for the GPs who are listening that might be interested to go into this in a little bit more depth. There are some fantastic resources out there that actually just create more understanding of the conditions and how to put those all together. Something that I did want to backtrack ever so quickly. In terms of suspecting who might be hypermobile, if a dancer or a gymnast or a contortionist comes in to see you, you could be pretty sure that they're hypermobile. Now, while that is amazing, while they're fit and they're strong and they're active, the biggest problems come when they are no longer doing that. So they're losing that input of muscle strength. Then the issues can really take over. Sorry, I wanted to jump in with that before, but Jade was doing such a beautiful job. I didn't want to.
Or not just if they stop on retiring, or if they have to stop temporarily for illness or injury. As you said, our wounds heal slower. So after surgeries, after injuries, our wounds, you can pretty much estimate, will heal it'll take twice as long to heal. So we need to not use the dissolving sutures because they dissolve too quickly and things like that. But unless you have a hypermobility informed rehab program, you can actually have a lot of difficulty getting back into action. And it's like, while close to 70% of ballet dancers are hypermobile, if any kind of athlete has recurring injuries, either in the same location or injuries in multiple locations, that can also be a really big clue.
And when we're trying to make a diagnosis here with all these potential varied symptoms, does imaging have a role? Can it be helpful?
Ultimately, it's not the first sort of go-to. Obviously, routine imaging is not going to be diagnostic, particularly for hypermobile EDS. But where imaging can be useful is things like dynamic ultrasound. Can we see, and this isn't available to every GP, I understand that, but you can demonstrate excessive joint translation or tendon subluxation under dynamic ultrasound. The upright or flexion extension MRIs, obviously we can get a little bit of an idea of quality of movement. This is particularly important if you have craniocervical instability or a tethered cord. If you suspect those sorts of things, you're going to get some information from that. But again, that's not routinely available. The real sort of thing comes with understanding that imaging, while it supports your clinical reasoning, it doesn't replace it. So in terms of where we need to be going is that hypermobile EDS in particular, it's a clinical diagnosis, but it's based on history and examination. Jade might want to speak to the 2017 diagnostic criteria, but she's also brought to my attention that that is going to be updated next year. But there's no known genetic marker at this point. So standard imaging, it can't confirm or exclude EDS. You're going to get a lot more information by listening to the patient, what it's got to say.
Yep. Well, one of the big things with diagnosis is most GPs think that they have to refer out for diagnosis, and that's actually a myth. GPs can diagnose. It does not have to go to a geneticist or a rheumatologist, and actually a lot of the specialist clinics don't take patients who have suspected hypermobility. And you can go to rheumatology websites in Queensland, and they say, we are not taking patients looking for a hypermobility diagnosis. That is something that a lot of the GP community doesn't seem to be aware of. And if this conversation can help them have the confidence to give a diagnosis, even if it is a tentative diagnosis, and start to manage the symptoms and manage the treatment plan as if that hypermobile diagnosis was in place, that can be a very, very strong way to move forward.
So what does that treatment plan look like if a GP is suspecting hypermobility and the patient has some of those symptoms and signs that we've already mentioned? What would a treatment plan look like?
Jade, I'll just jump in here because I'd love you to answer this question, but some very interesting conversations that you and I have had are around naltrexone. So as a first go-to, I'll ask you to expand on that.
Yeah, this is starting with a dysregulation first lens and a mast cell management first lens, because if we can reduce the overall sensitivity, the activation level, and increase when I say we need to increase muscular activation and reduce mast cell activation, and low dose naltrexone and things like the Ryaltris nasal spray and sodium cromolyn, these are all things that are very, very helpful at reducing that overall inflammation threshold. Ryaltris and cromolyn, you can tell within a few minutes if it's helping. So that's something that I know that allergist immunologists have had in clinic, and they will just use the nasal spray with a child who's very, very sniffly or has other systemic mast cell and inflammatory issues. And they can tell within a few minutes if the itching stops, if the temperature regulation improves, if all of that, you can tell within a few minutes. With low dose naltrexone, that can take several weeks before you can notice, but it's very, very, very helpful. Naltrexone overall at the full dose, the 50 milligram dose, that is indicated for alcohol dependence, but at the low dose, which is a maximum of 0.4 milligrams, but we usually start at 0.1 or lower and gradually titrate up every fortnight or so. Low dose, they don't quite know the mechanism yet, but it seems to be having an effect on the receptors in the fascia, on the receptors that the mast cells are connected to, whereas the higher dose seems to bypass that and go direct to the brain, so it's for the alcohol dependence. But yeah, low dose naltrexone was recommended by pain clinics and things like that. It can help with the pain management, but it's really helping with this aberrant mast cell activation. And that's been very, very helpful. So we'll probably start with a Ryaltris nasal spray or a cromolyn for first shot and reacting to symptoms in the moment, because you can tell within a few minutes if they're helping and they don't have a long lead time, and have the low dose naltrexone as a longer term thing. But if you start with that, then if all of the body is dysregulated, you can actually turn the volume down on that first, and then you can start to go, okay, while that is settled and it's stabilized, then what are the other symptoms, the other things that we're working with? So then it's a matter of regularly going through each of the comorbidities. The second one after the mast cells that is most disruptive in lives is POTS. And you guys have magnificent resources on POTS in the portal here for the podcast and the articles. Yeah, so we start with mast cells, then go with POTS, and then being able to have exercise routines that you would give to the fragile or the elderly, right? So things that if you're trying to do falls prevention in the elderly, or you're trying to do rehab after a stroke, you're not going to do, or someone that's got concussion, you are not going to push them too far. If you use the lens of stroke, elderly, and concussion for the exercise prescriptions for these patients, you're not going to push them too far into the injury zone, especially if we manage the inflammation and the POTS and the autonomic dysregulation first. But exercise is magnificent when it's not making things worse.
And Alison.
If I can just jump in there, one of the things that I've found really, really helpful in the initial stages is basically isometric type of stuff, because you're not necessarily going to have disruption around the joint. You're not going to flare pain. And I think the point that Jade made about, trying to calm down that reactivity in the tissue and then having a capacity to build strength on top of that, getting people moving more effectively, people don't feel quite so incapacitated if we can get those sorts of things up and running. Jade said that, that a lot of hypermobile people are actually very strong. It's getting access to that strength.
And the last piece, the EDS clinic down south has been getting the GPs there have been getting really good results with patients for hypermobility and POTS and mast cell with at-home oxygen, just 4 litres per minute, 10 to 15 minutes per day. They've been getting a massive reduction in symptoms and an increase in capacity for everything. Like, they've had people go from not being able to leave the house without injury and issue to having much fuller lives again. And then the other non-traditional one is heat therapy, far infrared saunas and things like that seem to, much like the isometrics, activate the muscles, activate the fascia, activate the sweat response without the risk of injury that you can get from jogging. And so the far infrared sauna therapy and even like cold therapy and things like that are very effective. The fact that these bodies are so responsive, and most of the time they've been responsive to things in a negative way, but they're also very responsive in a positive way. So as soon as we have a few of those little foundation blocks, and even looking at subclinical levels on bloods of oxygen-related things like iron infusions and B12 supplementation and things like that, there's often, with B12, we're usually not out the bottom threshold, but we're in the lower half of the healthy threshold. If we're under 500 to 800, again, think about the elderly. You want the elderly to have a much higher B12. You want this population to have the same level.
Well, listen, we've covered so much today, and I just wonder if we can try and wrap it up so that we've got some important takeaway messages for the listeners.
I think the first and foremost, is for GPs to be a lot more confident about getting that thorough history, what's happening now, what happened last week, what's the most prominent symptom at that time. And GPs need to take ownership of that, because, a lot of the other rheumatologists, for example, they're just completely blown away by all of this. But that whole multimorbidity thing, I think the second thing is that pain control that Jade spoke to. I think that's super important, because ultimately this is what's going to improve people's quality of life, and that through increased functionality, more engagement, not being frightened to leave their homes. I think that's terribly important. Jade?
I think you are seeing these patients more often than you think. Once people become aware of this, we've had GPs report that they're seeing multiple of these patients per week and per day in their clinic. They just weren't recognizing them before. So this is a lot more common than you think. And if you have a problem patient or a frequent flyer or someone that's got everything wrong, it's not actually a problem. That's a clue. That's a starting point to suspect and work in this direction. And I think the second thing is to actually have a compassionate and collaborative approach with these patients, because if they are still coming to the doctors trying to find solutions, you're probably not the first person they've seen, and they have been dismissed before. If imaging results are negative, that doesn't mean that nothing's wrong. Negative imaging results is not as reassuring as you think when you still have a lot of unanswered questions, and being told that there's nothing wrong with you is very different to saying the imaging didn't show anything, but we're going to figure this out together.
Well, Alison Slater and Jade Barclay, thank you so much for joining me. This is a huge, evolving and very interesting topic. And I think, Jade, as you just mentioned, GPs would be seeing patients with these types of conditions and symptoms much more often than we perhaps realise or we're able to put together. So I'm very grateful to you for being with me today and for sharing your insights on this topic.
Thank you very much, Rebecca. It's an absolute privilege to chat to you today and to the listeners out there. Very grateful for that opportunity.
Thank you so much.
Health Ed's hassle-free CPD just got even more hassle-free. You can claim CPD with one click after listening to each podcast. Plus, if you're an RACGP member, we'll lodge your CPD with the college on your behalf. With each podcast episode, you can now earn half an hour of EA and an optional half an hour of RP. When you finish listening, just click the orange Claim CPD button on the episode's webpage and claim your CPD hassle-free.
Just a quick reminder as we wrap up to encourage you to register for the next webcast, where you can always catch a high-quality lineup of speakers and topics that Health Ed has put together for you. Health Ed webcasts are carefully created to provide high-quality video and audio so that you have the best possible learning experience. It's free, you get CPD points, and it's all delivered directly to the digital device of your choice, wherever you choose to be. Register now at healthed.com.au.